Grani ki ana ki te whenua, ki ana ki ngā tupunei te pō, ki ana ki ngā uri I te awa tēnā. Tēnā koutou katoa. Kia ora koutou, ko haere mai nei. Ki te whakaaro I te upu tā whānui. Ki ngā mana whenua I konei, I te upu ko tika, tēnā koutou katoa. E mihi nui ana ki te wānanga o tākau I tēnei hui a tāhua, mō ki ngā manuhiri konei, tēnā koutou haere. Nā reira, kia tātou, kia pai te hui nei, tēnā koutou katoa. Kia ora everyone. Yes, thank you Michael for the introduction. For those of you who don't know me, my name is Jack Tame. I'm a journalist and broadcaster. I would say I probably have the least public health knowledge of anyone in this room, which makes me a curious option for the facilitator in this panel, although I may be the only person who has a first-hand experience of the MIQ process at the Distinction Hamilton. So that gives me a unique perspective. We are very fortunate this afternoon in that and that we have the Rolling Stones of pandemic response gathered here today. I mean, it is very rare, I think, that we actually have an opportunity to benefit from the experiences and the expertise of our panel today. So I will very quickly introduce our panellists, and then my plan is pretty much to get out of the way. I'm going to open up the panel with a couple of broad questions for our panellists to consider in their respective fields and areas of expertise, and then, as Michael mentioned, we will open the floor to your questions. So our panellists this afternoon, the Deputy Prime Minister of New Zealand and the Minister for Finance, Mr. Grant Robertson, kia ora. Teresa Wall is the co-leader of Te Rōpū Wakapapa Uruta, the National Māori Pandemic Group. Professor Ian Towns, the Chief Science Advisor for the Ministry of Health. He is a physician who's published extensively in respiratory health. Professor Michael Baker, I'm sure you all know very well, is an epidemiologist and member of the Ministry of Health's Pandemic Influenza Technical Advisory Group. And of course, Dr. Ashley Bloomfield is the Director General of Health. Maybe the Rolling Stones of pandemic response was inappropriate. It's like the 1995 Chicago Bulls. and I think, as I say, what we will do is I'm going to throw it open with a couple of broad questions. Panelists, I will ask you each to answer the questions from your area of expertise. And then if any of you have things that you want to say, if you want to interject or offer some other insights or experiences, please do so. Don't be backwards in coming forward. Don't be embarrassed to be self-critical at times, Minister. And perhaps we can start by asking, what has New Zealand got right in the pandemic? That is the biggest patsy you're ever going to get.
Tēnā koe, Jack, namihi nui te koutou katoa. A lot, and I could probably move the microphone on. I think New Zealand has got an awful lot right. It does not mean that we're perfect, obviously, and that's probably the whole purpose of your being here today, is to be able to work through a lot of that and what we've learned. But you know, we did get an enormous amount right. I mean, we're about to be joined, I think, by Nikki Turner as well. And at that point, other than the Prime Minister, we'll have all of New Zealand's leading epidemiologists in the room. The Prime Minister, as various members of the panel will know, has developed a very rapid understanding of a number of quite complex matters that have had to have been dealt with from a medical and public health side, and possibly the favourite memory of her colleagues is as she began talking the ESR staff through genomic sequencing. It was very important that they learned it from the Prime Minister. But that's a roundabout way, Jack, of saying one of the things I think we got really right was the advice, the listening to the advice of experts and scientists. I think it's one of the fundamental things New Zealand did that a lot of other countries didn't. There are improvements we could make to that, which I can come back to in a later part of the question, but the fact that we did that was vitally important. I do still think we did go hard and early. There are people in this room who wanted us to go harder and earlier, but we did do that in terms of our approach. I think we developed really strong social license for what we were doing. and I regard that as one of the really vital and important things that we did well. We had to take New Zealanders with us on this journey, and that's a not quite defensive comment yet, because I think it's one of the reasons we didn't move sometimes at the speed that Michael and Nick and others were encouraging us to move at, was because we were highly conscious of the need to build that social licence. The last thing I'll say in this bit about what I think we did well, which is very much from my perspective, is we took a wellbeing approach to our response to COVID. And though most of you in the room will know that that's been the philosophy that I've tried to bring to my job as Minister of Finance, is to take a wellbeing approach. And that meant that we looked at the full spectrum of cost benefits analysis, all of that we could, not just about money, but about how we could actually keep New Zealanders healthy and well and alive, and how we could build social capital. And that actually helped get us through. And so I'm extremely proud of the fact that the words we uttered very early on in this process were, which in my case as the Minister of Finance, were to say that the very best economic response was a strong public health response. And we meant that, and we kept at that. And I think we've been proved to this point to be correct that the best economic response was a strong public health response. But I still come back to fundamentally that we listened to the people who are sitting next to me, and that has stood us in enormously good stead.
Kia ora. I can't disagree with the Minister that New Zealand has done extremely well, and I think that Michael in his talk this morning said that our strength was taking an elimination strategy. That was the thing that carried us through. The other thing, of course, was the fact that we had a Prime Minister who had a history of being able to take the country in the face of 2 disasters. So we had confidence in her. So I think there was a political leadership there that we were in a much better space to respond to COVID. So I'll talk a little bit about things that I think might have needed to be improved.
Well, kia ora tātou, Ian Towns my name, as it's been mentioned. I am a recovering academic, and it's great to see a number of former colleagues here, but also to acknowledge the active participation of academia in the whole conversation that we've had as a nation. Also a big shout out to a number of Ministry of Health colleagues who I can see in the audience who've worked so hard to get to this point and supported the effort. So as Grant has said, the science-led response, I think, will go down as one of the defining moments of the whole New Zealand effort. It was science-led, and I really want to shout out to Professor Juliet Gerard, Dame Professor Juliet Gerard, who worked with myself and Ashley and Caroline McElnay really on a daily basis during those white-knuckle moments in March and April, where we were dawning this idea that we might be able to achieve elimination. And as Michael and Nick and others have observed, we didn't actually know what that was at the beginning, and so we were helped with some definitions from our colleagues. It wasn't eradication, it was elimination, and as we look back we can see that it became obvious that it was within our grasp, and that was exactly the reasons that Grant has said that the Prime Minister took that early aggressive action, and we all endured a prolonged lockdown, but one that has paid handsome dividends. I spend a lot of my time at the moment talking to colleagues overseas, and when I tell them what happened here, they say, well, what was the secret sauce? You know, what was the thing that made a difference? And it was absolutely basic public health measures at the end of the day. And while it was science-led, the interventions broke those chains of transmission, and that's what made a massive difference. I also just want to shout out to our colleagues at ESR, that have been mentioned, the whole genome sequencing. It's been a game changer for us. We've stood it up in a remarkably quick period of time, and you can see from actually stand-ups that this helps us understand what's happening with the clusters and the outbreaks. So a big shout out to everyone who's been involved in the laboratory science there, some of the unsung heroes. Kia ora.
Kia ora koutou. Look, I just have to agree with everything that's been said. The key difference in New Zealand was this fusion of good science and good political leadership early on, and there were a lot of reasons why we succeeded, and I think this is really also, I think, a tribute to the chief science advisors who gave a direct link between academics and the scientists and our political leaders in the Ministry of Health and in the Prime Minister's department. And Ian was always the go-to person, I found, in those early, really tough times to actually inject more science ideas into the discussion. And particularly as time has gone on, I think the evidence base for elimination versus suppression has just got stronger. And it does seem this idea of path dependency, once you make a choice, it's a bit like going down a valley system. Well, if you're heading down the wrong valley, it's very hard to extricate yourself. And I think we were fortunate in New Zealand, we could observe the experience in Asia and the experience in Europe, and we chose the right direction. And it is fascinating now, there is almost an Asian Pacific approach compared with the Western world. And I think some of these ideas obviously will come up in the discussion with Helen Clark this evening about the role of the World Health Organization. And I think at that critical time in New Zealand, instead of looking to our traditional sources of science knowledge, because of course science depth in New Zealand has always been limited, we always look to not just WHO, but European CDC, the US CDC and Public Health England and so on for models, and we weren't getting them. And a lot of things come down to risk assessment and risk management. The risk assessment was not great, and the risk management leadership was very poor. And so I think fortunately New Zealand chose the right path at that point. And since then, I think a lot of things have been, not quite details, but I think once we're heading down that path, it's been refining it and making it work better. I also just really congratulate the government on prioritising public health ahead of maybe some short-term economic indicators. And the evidence, again, has just shown that the two go together, and that's been seen across the globe as the evidence comes in. Thanks.
Oh, kia ora everyone, and thanks Jack. Nice to be here this afternoon. I'm looking forward to Nikki arriving, so the panel makeup looks a bit more like the makeup of the audience. Look, I concur with the comments that have been made, and I just want to add two things, actually three. One is don't underestimate the role of the whole New Zealand public sector, as they had shown previously in responses 2 years ago to the Whakaari White Island eruption and the terrorist shootings in Christchurch. They're magnificent in terms of their ability to respond tactically to these issues, and the work across government was unbelievable on a whole range of measures, and I'm sure you could get the Deputy Prime Minister going on. The work by the Treasury and MSD was just so timely and fantastic as part of the whole effort. Alongside that, the work of everyone across the healthcare system and communities who mobilised. And the way I like to think about, and I saw it happening in my organisation, people saw what needed to be done and just did it without waiting to be asked or waiting for permission. And it was liberating and amazing in terms of what we saw, what happened. And part of that was down also to incredibly clever communications messages that the All of Government team put together. And I've talked about the stay home, save lives, be kind as just brilliant, a brilliant call to action. So everybody in their individual bubbles could still be part of a collective effort. And the call to action to be kind was, again, I think quite profound. And finally, I think a lot has been written about the value of New Zealand's, of the communications behind. I've touched slightly on that. But a key feature of the communications was communications with humility. And it was right from the start being prepared to say, and I can tell you, I remember the very first stand-ups about a year ago they started. Most of the questions, my response was, I don't know, or we'll see if we can find it out. Not long after that it became, yes, sorry, we got that wrong, but we'll see what we can do about it. And that continues, and I guess the second part of the question that's written here is what will we do again? Actually, we must keep doing that, even as we go through the challenge of continuing to keep the virus out of our country, but also vaccinating as many people in the population as possible. It will not be perfect, and we will keep having to say, yes, actually that doesn't sound right, and this is what we're doing about it.
I might just pick up something you referenced there, I had the great fortune of being in DC for the election of Joe Biden in November, and I was, cognizant of the fact that 110,000 or 150,000 people a day were testing positive for COVID in the US at the time. I had the interesting experience of going through Prince George County, which is the largest African American majority county in the US, and then driving a couple of hours west into West Virginia. I'm not sure if anyone here has been to West Virginia, but it's a beautiful but economically deprived area, predominantly white, and it's where Trump has some of the largest support-based percentages in the country. But it was fascinating to me to see the completely different approaches of those two communities. So through Prince George County, for example, literally everyone was wearing a mask always. So you'd see people jogging, people were wearing masks. You'd see people doing sort of CrossFit style exercise in the park, literally everyone was wearing a mask. I went into West Virginia the next day and walked into a shop, and I was just unsure about this before, and no one was wearing a mask. And I said, has the virus been through you? And I said, the guy who had the shop next door died. He said, okay. Do you know anyone else who's had it? Yeah. My uncle died, and my next door neighbour's father died. Right. No one's wearing a mask, and it didn't just reinforce to me how the politicisation of the pandemic had caused massive problems over there. But it reinforced to me the importance of a collective response, right? It's all well and good having a great scientific team and great work within ministries and the public service, but you have to get the public to buy into that message. And when I look at New Zealand, even comparing us today with the UK and Boris Johnson standing up at his various press conferences, there is a common language around the pandemic in New Zealand that I just think has been extraordinarily effective in getting people to work together. Think about the alert level system, 1, 2, 3 and 4. But the different rules under the alert level system have changed, multiple times over the last 10 months. But it doesn't matter, because collectively we all have a language for something that is relatively complicated for the average person. Everyone can say, right, I understand the risk right now, we're at alert level 3, or we're at alert level 4, and everyone can buy into the progress. There's narrative when you say, we're at 4, you do this, you go to 3, this, you go to 2. Everyone, it doesn't matter how well versed you are in public health, can buy into that messaging. And I just think that had a remarkable impact in benefiting New Zealand's response. And I look at these, comparatively advanced economies and think, if only they had a good PR team coming up with a few snappy slogans. And honestly, things could be totally different. Minister, what did you get wrong?
So this is the bit, Jack, where I'm going to hand the microphone down and then be the last person, if that's all right. Because actually, in all honesty, I'd like to hear a bit more from this, and then I'll respond. I will.
So I think one of the things that initially the government failed to, and officials failed to do, was to have a focused messaging for different population groups. It was a one-size-fits-all approach, and some of the messaging was somewhat, a little bit blaming, and the notion that Māori weren't able, or Pacific people weren't able to actually take the message and adapt their own ways of doing, and tikanga and things like that. So I think that and it's still playing out, I think. I don't think that government and officials really have come to grips with, we're now in the 21st century, let's get a little bit more sophisticated about understanding what the populations look like and live here in New Zealand.
Well, kia ora, Teresa, I agree with that, and I was a bit slow myself to get members of your team onto our panels, and so totally accept that. And we did commission some research at the Ministry through the HRC about the role of Kamatua in leading communities, and when they came a few months ago to present to us, it was truly humbling to learn the influence, but also the amazing common sense of the Kamata of leading and protecting Māori communities. So kia ora to you on that. Well, otherwise it was all perfectly formed, of course. Jack, like a royal public servant, I couldn't possibly admit the really failings or gaps. I guess Professor Sir David Skegg has had the most hard-hitting commentary, and it was about preparedness, wasn't it? It wasn't really about the actions of individuals under desperate circumstances, but rather as a country we weren't as well prepared, and I think we've all agreed with that analysis. And there's a lot of work to be done, obviously, that Ashley and Minister Little and others are going to be leading over the coming months, and that pandemic planning and the need for surveillance and a strong public health system, I think, partly answers the last question. I was new to government, so I found some things quite interesting to observe, and one of them was it was actually quite tricky getting different agencies to work together. And I don't mean there was any ill will or personality clashes, it wasn't a practice kind of scenario. So I think that's something we could do better in the future.
Thanks. Look, a lot of today or this afternoon has been talking about what we could do better, what we could learn, and obviously it's an ongoing process. My main observation was the slowness of taking in science advice and turning it into action. And the essence of risk assessment and risk management is that you keep doing it. It's an iterative process. And I think our core direction, as we discussed early on, was very appropriate. But after that, it was all the refinements we needed to do. And the principle of getting ahead of the curve, getting ahead of the virus rather than trailing it, was we just learned all around the globe that was what made the difference. And I felt that not only there were some examples of things we were terribly slow at adopting, but also our mechanism, thinking about our process for actually absorbing input and also integrating it at a high level. And so it did feel to me that we were really missing one element, which is this high-level strategy group, to try and pull the modelling, pull all the genomic data, everything together in one spot with policymakers. A very agile kind of decision-making, and I felt that has held us up for quite a long time. I know that there are always practical limitations, but there are a few examples where I think we were very slow and it has exposed us. I won't go on about the mask thing, but I think that is, or maybe I will. But I think it was a case study where we seemed to be almost the last country on earth to say actually the evidence is strong enough to justify mass masking. And actually it turned out maybe it didn't make much difference for New Zealand because we haven't really been stressed by a large community outbreak. We had a significant outbreak obviously in August. But that just seemed to me to be a bit of a litmus test issue. Why were we so slow to look at that evidence? And for a while it was we're waiting for the WHO to say mass masking is useful. They put out their guidance and we still waited after that. It wasn't, I think, a game changer, but I think it was a bit of a test case for using evidence. And then other areas where I think we could have been quicker, obviously testing, putting a ring around the border workers, even thinking about how to turn down the tap on that, what is our biggest single risk now of failure at the moment while we're waiting for the arrival of vaccines in that area. The other is, if this is a $50 billion response, we should have a similar proportionate research and development strategy going alongside that with a large investment and well-designed strategic objectives. And it's so we can not only refine what we're doing, but also so we can learn how to do this better. And the other thing at the moment, I think every decision we make about investing in the pandemic response, I think it also needs to go for another decision question: will this strengthen our capacity to respond to similar events in the future? And I think that idea of making sure all our investment has these two objectives that it's meeting. And I think there are a lot of things that we might invest in now if that was the case. And we talked about just this ability to learn as much as possible, and that not only is it the R&D, the high-level strategy group, having a dedicated public health agency, which I know is sort of one of the options under discussion, and also the idea of having an inquiry at a certain point. I know inquiries can divert people away from the response, but if we wait till the end of the pandemic, I'm not actually sure when that will be. I mean, maybe we can do a poll in a minute about when we finish. But it's going to be a long way off before we actually say things have changed and we can actually turn down a lot of our control measures. So how do we do inquiries with rolling threats and actually get more widespread discussion about how to do it better and how to do it better next time before we actually even forget? Because it can be a tendency 2 years down the track after it's over, people start to think, what pandemic? And they start to forget those key lessons. Sorry, that's a long list.
Thank you, Michael. Joe, thank you for hearing one of my talks about having a performance review at 1 o'clock every day, live on TV. So I never had to give too much thought as to what wasn't going right because the media would point it out to me at 1 o'clock every day. And if it wasn't at 1 o'clock, it was at 5 to 7 in the morning. It was either Professor Wilson, Skeet, Baker or Gorman with their latest, greatest idea. Just, slightly a response to Michael. I don't think it's important not to confuse a lack of ideas and strategic intent with the need to consider all the different issues that might go around that, and that's the difference between research and policy. And in New Zealand, even in our current response, and there's narrowly an idea that isn't being raised on the radio that our team isn't already thinking about, and in most cases actually busy providing good advice to government about. But even the difference, for example, between us and Australia, well, one of the things that's the same is we both have incursions resulting from our managed isolation facilities. So whatever Australia's doing is not necessarily a lot better than here. But one of the things that we have that the Australians don't have is a Bill of Rights. And so we get very strong advice on every single change we make in managed isolation, even the proposal, and it's a request, not a requirement, for people to stay that last 2 days in their rooms after that final test. Requires a strong Bill of Rights analysis. Is it justifiable under the overall objective around improving and protecting public health? And as it transpires, it's not underpinned by a legal order, so it's actually a request at the moment. So again, I guess just to, in a sense, speak for the bureaucracy, which can sometimes appear to be slow, we hoover up all the ideas, including a good one I read in the New York Times. There was a lovely article over the weekend about the organiser of the Boston Marathon having been co-opted into running the huge vaccination initiatives that they're doing there. And so I've already got the team looking at that here. We may have some underemployed event organisers. So we're happy to hoover up any idea. And in fact, I think this has been a feature of our response is our ability to constantly review, and that's why I favour constant review, improvement, adjustment to, especially at this point in time, the large inquiry. Thank you.
Yeah, I'm definitely glad I did it in that order. I do want to start, Jack, if I can, just with two things which are things that I think we both did well but could also have been done better. And the first of those is the whole of government response. So for anyone who's actually worked in government or around government, the site, and I've actually done a presentation to this very summer school before around one aspect of the wellbeing approach that we're trying to undertake, which is to break down the silos of government. And it's one of the biggest issues we have, and there's structural things that lie behind it, which we're trying to work on, as well as cultural matters. So that was both very good, that we had a whole of government group that stepped in and that brought together all that excellent messaging and delivered a huge amount of material and policy and programs for people, but it also had great limitations, and it still does today. And so that is something that's just a constant work in progress to get past that. But there have been some magnificent things that have occurred in making that happen. One point that I should have mentioned at the start was it turned out that having one meeting a week where politicians make decisions is not enough in a pandemic. So we had cabinet, and again, for those of you who've worked in government before, the nature of our cabinet government system is cabinet's the apex, and everything kind of works towards that. And we just couldn't do that. So we invented a COVID committee, a cabinet with power to act, that could meet on a Wednesday. And then it met on the Tuesday, and then it met on the Thursday, and eventually it was at some points meeting 7 days a week. But it could make decisions. And that was, I know this sounds like the most boring, pointy-headed public policy thing that you could say, but it was critical in our response, was being able to make decisions every single day in a system that's used to making them every week. But the other aspect of that was problematic for us was that the timescales we were all used to. And so the way I ended up phrasing it was what used to take a month is now taking a week, and what used to take a week is taking a day, and what used to take a day is taking an hour. And that's the pace that we were moving at, but the system is not well set up for that, and it still creaks and groans as we're doing that. So I think we could do better in that regard. The other bit that I think, which I pick up from Michael's original, actually Teresa's point first, and then Michael's as well, I don't think we got the stakeholder voice right at every bit of the process. I think it wasn't for want of trying, but we just didn't quite get it right. And the good news is we did something that governments very rarely do, and as Ashley has pointed out already, when we made mistakes, we rectified them and we changed. And that's something governments are horrible at, and you don't want to admit that you've got it wrong. We were having to do that constantly. I changed the wage subsidy scheme twice in the weekend. One of them, sorry if you allow me a 30-second diversion, we had a problem with the VPN, which we used to do our remote work. And so I had to drive from home, this was during level 4, drive from home to the basement car park of the Beehive in the shirt I'd slept in my tracksuit pants to type the email, to make the change to the wage subsidy scheme. But we had an ability to shift and change, and that's something we've been good at. But when it came to the right voices in the right room at the right time, I don't think we got that right all along, and it actually did lead to some things, mistakes. The next question you're about to ask us is around what we would do better, and how would we organise ourselves for a pandemic. And I do think we now know enough about what a whole of government group looks like. We now know enough about what stakeholder response looks like and who should be there and how to involve those technical voices. And so I think that's really important. And the other point I guess I'd make, and I could make a few more, but the other point I'd make around what I'd love to see us do better is our ability to alter. It's a similar point, but it's not the public sector this time. It's the way in which we make rules. And so public health orders, which became the bane of Ashley's life, we do have to respect the Bill of Rights, and we do have parliamentary processes, but the pandemic wasn't lining up with those, and we need to take another look at some of the legal frameworks that sit around the way we do that kind of pandemic work. And I don't think we got that quite right, and we're still kind of doing it, as Ashley said, by request or whatever. It's not about crossing over the Bill of Rights, but it's about having a system that understands how that works in a crisis and how the legal framework could be more streamlined for a pandemic.
Okay, thank you all. I might pick up on a couple of different points that you've raised. Minister, I'll start with you since you're next to me. A lot has been said, and from what I understand, Michael, a lot has been said today about our preparedness, where we were 12 months ago compared to where we might be now. Can you talk me through how having DHBs that are hundreds of millions of dollars in need is in any way a way to build capacity for responding to this sort of event? I mean, we have DHBs that they don't even have an integrated IT system, from what I understand. So how is our DHB system, in the way it has been functioning for as long as it has, prepare us in any way for this kind of event?
Yeah, well, I mean, the first thing I know it sounds defensive as a way to start, but the first thing to say is amazing work has been done by people in those DHBs over the last year. It's been absolutely extraordinary, but I'll accept that a fair chunk of that work has been despite the conditions they're working in, as opposed to because of the conditions that they're working in. So obviously it doesn't help that over the period of the previous national government, they $2 billion underfunded the health system. We knew I'd do that. But so yes, there's a huge job in rebuilding and putting the resources in. This also relates to what will be one of the most significant things this government does, which is the implementation of the Health and Disability System review. And that cuts to the heart of the question of the organisation of the health system. We've talked about public health authority, there's a Māori health authority proposal within that. There's a whole string of structural changes, and all of that will have to be accompanied by funding, of course it will. So no, it has not been easy as a result of that. Varying practice within the DHBs has been an issue. As you will know, the number of times we asked, well, why is the Auckland DHB doing this, but the county's Manukau DHB is doing that. That improved as we went. You know, we started to see much more coordinated action, but we do have a highly devolved, highly siloed health system, and that's the reason why we've reviewed it, and it's the reason why we're going to implement change.
Clear the debt.
Clear the debt, yeah. I mean, the debt's going, you know, there is reasons for why you wouldn't immediately eliminate all of it, but, you know, we have a debt sustainability program. Those who follow the Canterbury DHB's twists and turns and dramas will see that we've put significant money in there, but we'll work through that.
Could you also speak a little bit more to the speed of bureaucracy? And I know you formed a group that was able to make decisions much more rapidly than on a once a week per basis as per cabinet. But maybe if you could speak to it with the masks in mind, with the masks policy in mind, and why we weren't able to move more quickly on that front.
That had nothing to do with the number of decision-making meetings. It had to do with the advice that we received, and I'm not dropping Ashley into anything here. I'm sure he's capable of talking through how that worked, but we had extensive discussions about mask use at the cabinet table, repeatedly going back as further evidence would come from overseas, but we listened to advice. I mean, I can only recall one occasion where we went against the advice that we received from the Ministry of Health. That was to do with the opening of bars and restaurants, as it happens. But other than that, on mask use, we listened to the advice. So that wasn't a question around bureaucracy or difficulty in decision making. We were getting different advice. Michael and others were providing that, and it was being openly debated, but it wasn't caused by a bureaucratic problem. Do you want me to get Ashley to answer?
Yeah, I'm going to throw another question for Ashley as well, and get him to answer both, if that's okay. I guess from the media's perspective, one of the standout chicanes in the otherwise smooth ride was what appeared to be a disconnect between the information you were being fed from officials within your department with regard to people who were being tested, people who were working in those isolation facilities, and the message that you were able to give in those 1 o'clock press conferences. And I suppose the thing with public trust is that once you have it, it's an incredibly valuable commodity, but once you lose it, it's incredibly difficult to get it back. And perhaps that was, I know from my perspective at least, one of the most contesting times in the nature of public trust in the pandemic response. So can you just talk us through that a little bit and the disconnect and where kind of fault lay in that response?
Thanks, Jeff, and I'll start with the response to that. Well, the fault lay with no one, and that's why you saw me on national television as part of my daily performance review. It's a system thing, and yes, there were people who were saying, who's responsible? And I think what we do sometimes forget is the nature of the environment within which people were working at the time. I mean, the pace and the intensity was profound. And I do want to point to this, and it won't be lost on some of you in the audience, but I've been in the role 2.5 years. I started in June 20, that seems like a long time ago, but I think it was 2018. Just as there had been an underinvestment over many years in the broader health system and in public health, we had a very skinny Ministry of Health that I worked hard to rebuild the capacity and capability in. And so there were people who were doing extraordinary work in quite extenuating circumstances, who were doing the best they could. And yes, there was a big slip between cup and lip. But the point here is, and we know this in the healthcare system, you've got to back your people. You can't say, oh, that person failed to do their job. And the key thing was, and yes, it was probably the toughest time for me publicly, was to own up and say, yes, that didn't go right, here's what we're doing about it. It was probably the most obvious example.
What was the error in the system?
So the error in the system was, and I think it goes perhaps to the question you just asked the Deputy Prime Minister, and he's responded to so elegantly. Actually, we have an incredibly devolved system, and it was one of the recent meetings I was in with the Deputy Prime Minister. I'm sure you won't mind me sharing this. He made the comment. Actually, he's realised the ministry doesn't actually have any direct levers into the system. Now, I've got a number of incredibly strong indirect levers, and the most important one is the one in my pocket with lots of phone numbers in it. And there's never a time when I don't ring someone and say, can you just do this? And they would absolutely do it. But there's a real challenge in our system between translating the policy and strategic decisions into sure-footed, consistent implementation on the ground. That has improved a lot over the last year, and I think this last week has been a remarkable example of that. It has felt great being part of a response that has felt increasingly well-oiled. The response from both a public service, a health system, a public health perspective, I think, has gone really well. And the question about masks is an interesting one. Again, I would just come back to remember the advice we're giving government is not just about the evidence, it's about the context within which we're working. And one of the issues that we were quite worried about with masks was equity and the access of our most vulnerable populations to masks. So one of the things we wanted to be really sure about before we gave any sense that masking would be compulsory or required was that we could be certain that all people would be able to access them and the cost wouldn't be a barrier.
If I could just pick up on a couple of those things, Jen, if I may. So the strength of the public health system is its devolved nature, and of course it was its Achilles heel at times. So I think that balance of understanding. I mean, one of the things I said to some of my colleagues a few times is you don't need to tell doctors and nurses what to do; they will just do it. And what you need to do is trust them and empower them and give them the resources they need. And I think that just speaks to our commitment to people who face the public every day and provide primary and secondary health care. As you'll probably remember, a memorable day in May where I had a bit of a meltdown in the ministry about information and data flows. And as Ashley has said, the infrastructure that we were dealing with at that point was really not fit for purpose. And so when Ashley did make a mistake or was later shown to have not quite got it right in terms of numbers of cases and some other detail, it's because they were being manually extracted from multiple sources and put into spreadsheets. What we have achieved, I think, in the months since then is a much more production model where this information is coming to us freely. We've got a number of dashboards which we've worked with ESR, and they've provided us with much more real-time, accurate, single source of truth data, which helps us enormously in our day-to-day communication with the public.
Teresa, I just wondered if you could, and I know you've spoken to many people here today already, but could you unpack your critical point there a little bit more for us and perhaps paint a utopian vision of how things should have gone, how that messaging should have gone early on, and the stakeholder involvement should have gone early on from your perspective?
I'm not sure that it... Can I not answer that question and talk about something else that I think is much more of mind? That we've had this quite successful response in COVID, but it has created more New Zealanders living in precarious situations, and they're more likely to be Māori and Pacific because they started at a very different place to everybody else. So that's the one thing. There's the other thing is that government was able to find money to house the homeless and to increase the benefit and do serious other things in face of this crisis. So then what's the opportunity having done that? What's ongoing opportunity? And then the other thing is that we have created considerable service backlog. That we I and other white colleagues haven't got any sight of that we've actually identified plans for addressing those service backgrounds. So I think those are some questions.
You answer them.
Well, I also had a crack at your question maybe too, because it's something I've been giving a lot of thought to. One of the things that worked really well in our work with Māori populations was the use of whānau ora providers to deliver services. And around about Teresa Wall, we're doing over 150,000, close to 200,000 care packs were distributed via whānau ora providers. And it was that rather obvious conclusion that those people closest to communities were in a position to be able to deliver to them. Similarly, you mentioned around questions of homelessness. I mean, we were able to house almost every rough sleeper in Wellington and Auckland. Regrettably, we've moved backwards a little from that since then, but we were able to do that. Why were we able to do that? Because officials were empowered to work with those closest to the communities to make it happen. And so those lessons are well and truly in our heads, as to the fact that we need to realise the empowerment of people to trust, issue that Ian talked about before with doctors and nurses, that equally applies in providers, and also particularly in mining providers. In terms of what this has created, yes, and it's a terrible, terrible thing that you can track any recession in the world and see who will be the most affected by it, and it will be those who are already marginalised. And that is in our society, Māori and Pacifica, low-income people, also with the particularities of this pandemic, women, and in terms of employment outcomes. And so that again is what we're focused on as we're now putting together our budget. But that is one aspect of this, is that it has reinforced some of the things that we do well in New Zealand about the delivery of services, but the risk aversion of government, and that's politicians and officials, has, we can see through it in this case, but it's very, very hard to shift because of people like you, Jack. That's a joke.
Do you feel sufficiently empowered then, given you are a majority government, but given you've made some big calls when it comes to things like tax policy and superannuation? Do you feel sufficiently empowered to take what may be bold and expensive steps in trying to address some of those inequities that, as you say, are only going to increase in a post-COVID world?
There are focus is addressing those. What I feel empowered by is that, I think, to bring this back to kind of where this seminar is that I feel that New Zealanders have bought into the elimination strategy. I think if you should never peg an election result on any one thing, but one of the major things New Zealanders bought into was keeping themselves and each other safe from COVID. And so that, we've got three priorities. That's one. The second is accelerating our recovery, and the third is dealing with those big issues that confront us. So that's the opportunity that's in front of us. But it would be another conversation you and I'll have about what our mandate is, I'm sure.
It's a harder sell, isn't it? It's the sad truth. It's a harder sell. Politically, it is a harder sell than saying it's in your collective interests to scan every time you go into a building and do all of that sort of stuff, and to wash your hands and to not go to work if you're feeling sick, because that'll stop you from getting the virus. But if you did say to someone on, an above average wicket, are you prepared to make some financial sacrifices, for example, to benefit other communities? Much harder sell.
Yep, but that's what we're doing, and we've raised the tax rates, income tax rates, we've taken those decisions. I don't know, maybe it's because it's the beginning of the year and I'm still feeling very cheery about life, but I think that New Zealanders have had an experience where they understand a lot more about one another. And this was my reference at the beginning to social capital. I think our stocks of that have actually been increased by COVID-19, and I think that opportunity is for people to have a greater degree of empathy for their fellow New Zealanders and have experiences that they haven't had. This is a small, tiny anecdote, but if you think about it, we've now had around 1.7 million New Zealanders interact with the Ministry of Social Development for their income via the wage subsidy scheme, and understanding about the issues that come with uncertainty and precariousness that is the living experience of many people day to day has now been the experience of some other people. Now, it's a swift generalisation there, but I think there is the ability for us to draw on some of that empathetic response and continue to build that social capital.
Dr. Bloomfield, I think you're probably the best person to answer Teresa's point re our capacity to catch up on various services.
Yeah, thanks, Jack. And it's a good point made by Teresa. There is a lot of work underway, and I made a note here because I was surprised to hear it wasn't visible, and we need to get that story. We spend both an investment and an enormous amount of work in our healthcare system to catch up. And I dare say, just to, we've saved you a seat. I dare say, I go back to what were the 3 or 4 things that totally motivated us at the outset. Well, first of all was protecting New Zealanders and ensuring their well-being. The second was looking after our healthcare system. And if you don't look after it or don't protect it, we've seen in other countries what happens. So there was all that care that people would have missed out on, and they did miss out on some. We've nearly caught back up on that. I just want to pick up the substantive point that I think Teresa's made. If we think about it, because one of the questions was, what's the major change we'd like to see in New Zealand to prevent and manage future pandemics? And I wrote down 2 things. One was invest in public health infrastructure, and that is happening. And to the point that Michael made earlier about ensuring that our investments are legacy investments, and we're really conscious of that. So a lot of the ICT investment and other investment is with an eye to the future. But the key thing we can do to prepare better for our future pandemic is to address health inequities in this country. Because not surprisingly, those are the populations who will do worse when there's not a pandemic, and do even worse when there is a pandemic. So we've got to, that's our major and should be our major focus from here. I'll hand you back the microphone because now I can see you want to ask a question.
I think we've answered them all.
Dr. Nikki Turner, or Associate Professor Dr. Nikki Turner, of course, is an academic with background in general practice, and Director of the Immunisation Advisory Centre. Hi everyone, thanks for being here. I've asked these guys already what we did right and what we did wrong, so perhaps I can ask you both of those questions. First up,
with the pandemic.
With the pandemic response, what did New Zealand do right and what did New Zealand do wrong?
Kia ora, and I apologise for coming in late. Thanks for the opportunity. What did we do right? I think the resounding message at our end is the team of 5 million. I don't know what everyone else said, but that message sung from the same song sheet, same messages, coherency from the science sector, the health sector, the Minister, Ashley, everybody sang the same tune, and the country believed it and supported it. So that's what we did right, and that is still what everybody's saying to us. What we did wrong, and what we may do wrong more, is take our eye off the ball on other things. We've really got quite a lot of challenges, and I'll just speak on behalf of primary care since I presume that's my end of the patch. There's a lot of shaken primary care sector out there. They're very tired, hence that I'm late today. They're very worn out. There's a lot of change, there's a lot of exhaustion. The flu distribution vaccine last year did not go well, and there's a lot of damage and lack of confidence in that. We're not currently doing very well with other issues like our MMR catch-up program. Our childhood vaccination program has dropped off a little. The issues around the fact that at the moment the services squeeze, the equity issues increase, and we're seeing that already. So that's, I think, what we've got to focus on, is not lose the sight of an integrated health service in our race for what we've got to do next. And since we're right in the middle of getting ready to rock COVID vaccines out there to the world, we've got to walk it with everything else, with primary care being behind us, with the whole health sector being behind us, with us still managing to sing the same tunes and the same communication messages, even if they're from different mouths and different people. But as a health sector, we stand strong. As a health sector, if we stand strong, so will our people, And from my end of the perspective with vaccines, vaccine hesitancy rises when we get those things wrong. So the answers lie within us. That would be my suggestion. I hope that covered the question.
Thank you. I might ask each of the other panellists then to do their, what is the number one priority? What major change would you like to see us make to improve our preparedness for a similar event in the future?
I'll do mine from that government perspective, bearing in mind all the different perspectives we bring, and it is effectively having the standing whole of government approach. So actually having that both as we be the method by which we work, but also have it ready to roll immediately, straight away. And that's where all of the good things and the bad things we've been hearing about today. I mean, I've got a whole lot of other things, but that, to me, from the bit of the shop that I'm involved in, is where we weren't quite there when we kicked this off. I mean, it's long forgotten we had a pandemic plan. We used to talk about it quite a bit in the first few weeks, and then realised that it was useful, but it wasn't sufficient. And so, yeah, I want us to have a standing facility to be able to do whole of government response to pandemics.
The thing that I think we've got an opportunity, and as I've said before, we've got an imperative to think about what the future looks like, so we don't go back to the normal that we've had, that we actually have a health system that is pro-equity, that is treaty compliant, that is anti-racist and culturally safe.
Well, here we are in a university lecture hall, and I've never met a researcher that didn't call for more money for research, so let's get that out of the way. And I'm sure it'll flow like a river of gold from here. But seriously, we were handicapped by the lack of specialist expertise in infectious diseases, and I'm sure our colleagues at ESR would agree that the infrastructure surrounding surveillance was not fit for purpose. And so those things need to be fixed. They're complementary, as Michael and Ashley has said, to the rebuilding of the public health intervention structure and the network and the leadership there. So those two things have to go hand in hand.
Thanks, actually, you've given me a good inspiration there, Ian, about more research, of course. But no, actually, I made one other observation about one of the huge lessons, I think, from this whole episode is looking globally how good governments save lives and bad governments kill people. And it's been shown over and over again, looking globally. And I think if anyone doubted the value of government and interventionist government, this has been such a life lesson and why we need the organised efforts of society, why, I mean, that's one of the mantras of public health, but I think there's so many things. And I think now New Zealand has huge agency to tackle these obviously huge existential threats on the horizon, and I think we can really use this case study. I think it's very reinforcing for us getting together to work on these problems collectively. And of course, the number one change, I hope, will be public health infrastructure. And one reason we spent a lot of time working with the epidemiologists in Taiwan and writing a paper, which was in one of the Lancet journals, was to compare New Zealand with, I think, the country that had the best response in the world. And they didn't need to lock down because they had that dedicated agency. It had everything ready to go. I think pretty much, Grant, what you're talking about. And I think globally people will have learned that lesson, I hope, for all nations, that, and also for the World Health Organization, you have to have that dedicated investment. And it actually pays itself, it's very cost effective, because it's so much more efficient to have that agency ready to go, and not just for pandemics, but a whole range of public health issues. And we all know prevention is better than cure, but we actually do not run our society on that basis at all. So that, for me, is the biggest single lesson from this whole episode.
Thanks, and I'll just add one more thing to the 2 points I made earlier, and that is I don't think we should underestimate the importance of leadership across the system in our response. And if we reflect on the fact that we had a public health infrastructure that was undercooked, The Health Security Index had of course shown that the US and the UK were the best prepared countries, and we were I think 32nd when that was put out in late 2019. The point here is it doesn't matter how much your investment is, or indeed arguably how little, if you haven't got really good leadership across the system, then it's all for naught. And leadership is not a thing that happens by chance, and I think we need to look at how that leadership was expressed and how it succeeded right across the system, and we should invest in, because leadership can be learnt, it can be practiced, it can be nurtured, and we should be really looking hard at how we can strengthen our leadership across both the health system and of course the public sector as well.
I think there are two key underpinning things I'd start from. The first is trust, and the whole concept of trust. How do you create a resilient community? You need to have trust in your government, and when we make mistakes, then we've got resilience to carry through, and we have trust in our scientists and our health services, and we have an integrated health sector that the community trusts. So that is right from the front line provider to the community, right at all levels of the system. We do not spend enough time thinking about where things go wrong and how we can correct it, and being quite relaxed and open about that. We can do a lot more to create a more resilient health sector right from the government down. And the next big issue, and this is a huge international one, is equity. You know, we all need to continue to be ashamed of our record internationally and locally on equity. And I know there's been a plea for public health, but I would like to reflect, Michael, that primary health care is equally important as much as public health. But I'd like to plea for integration. These two run together, that a public health service should not sit apart from a primary health care service, that they run together inexorably. Is that the right way? I'm not sure. So that's an exact problem. But so I really plead with us that we need more integration ourselves across our own language. And in that way, when we've got a functioning, effective system, I know this in the organisation world, our community walks with us and trusts us. And when we are functioning well with the government, even if we throw brickbats in public, at least we're essentially the same messages, and that we are actually seeing the same science tune for our community, and then at least people believe we're all on the same page. So trust and then equity, they run together.
I'd just like to pick up on a couple of your comments, which I agree with fundamentally, but trust on its own is not enough, as we know, because in Sweden the public trusted their leadership and they had the wrong strategy. So you have to have, I think, still demonstrably the wrong strategy. But in the end, a lot of people explain to me you need strategy and you need delivery. And obviously, in a health system, if you have one without the other, you're in trouble. So we can't, I don't think in many ways, I know we've been asked to come up with one thing, but it's a number of things working together. And there are many examples around the globe with this pandemic, which is obviously a huge stress test on many systems, that they failed because several of those elements, or even one of them, was missing. So anyway, just a reflection.
I'll ask the panel just one big question, which a couple of you have touched on, and I'll give you each one last question and we'll throw open the floor to questions, so get thinking. I mean, the international response from those of us who don't work within the field of public health has appeared to be at times incredibly impressive. It's the speed with which vaccines have been developed, and diabolical in other instances. And of course, some of that has been through political leaders, those who need not be named, who have perhaps undermined some of those multilateral institutions more than any other leaders in living memory. But there's some major lessons for countries at the end of this pandemic, whether it's working together or the importance of those multilateral institutions and making sure we are better prepared for the future. Is anyone else want to answer that?
I'll just say a quick thing, because obviously with my long experience in public health, I'll hate this. I'll just say, I mean, I'm not going to comment on the individual country responses. I think they speak for themselves, to be frank. But the thing that I think Helen possibly will say something about this tonight, I've actually had a conversation with her about it. The United Nations system went a bit missing during this. The WHO, I'll exclude the WHO out of that for the moment. They were doing a certain set of things. But that was one of the places I used to work there. It was one of the places I went looking for, and I didn't see it. And I think that's really disappointing, and something that is worth thinking about in the future. It's a little bit like us in New Zealand saying the whole pandemic responses, actually in the ministries and everybody else could just go home. That's clearly not true, and yet that's almost how the UN system approached it. So that's I'm 20 years away from having worked there now, so I'm not close enough to know exactly what went on there, but from the outside, I didn't see it.
Well, I think the most encouraging sight I've seen recently was Dr. Fauci hesitantly returning to the microphone after what must have been the most extraordinarily professional challenges that anyone could face. So I think we need to let our institutions do their job. And so when there's interference with that, that's when problems start. I suspect we'll hear later tonight about climate change and getting back on board with that, but also the need for nations to have collective action and to really trust each other and fund it appropriately. That seems to me the model that the science community demonstrated. They demonstrated they could put commercial and science competitiveness aside and develop vaccines with extraordinary speed that look as if they'll be a game changer for the world's response to COVID. So those are the things I'd like to see emulated in our other multilateral institutions.
Yes, well, I think we'll hear more tonight about the review of WHO, but I was very pleasantly surprised by the second report, preliminary report, which just came out, I think, last week, wasn't it, from the group that Hannah Clark is co-chairing. And I think it was very direct, saying that both the World Health Organization and China, their response was too slow and inadequate, and that affected the course of the pandemic. There was an opportunity when it could have been contained. The evidence was there. I was hugely influenced by the WHO Joint Mission report to China, which said it's been stopped. Wuhan contained this virus. It did almost the impossible to stop the pandemic in full flight. So why didn't the WHO act on their own report and actually say, here's a model for containment? It was already turning into a global pandemic. They just hesitated, and I guess we'll eventually get a better understanding of why they hesitated at that critical moment. So obviously the implications for the future is that they don't hesitate in that way again. So we need to have structures that are as responsive or fit for purpose, which means in pandemic situations you cannot delay. You have to do essentially what New Zealand did, going hard and going early. That is the default option. When you see a pandemic of sufficient severity, you have to adopt that as your default option rather than going through a very bureaucratic process.
Thanks. Just to build on the comments that have been made, I spent a year at the WHO. It's hard to believe it was a decade ago now. But for longer than a decade, member states have been talking about WHO governance reform, and virtually nothing has happened. And the reason is because the current governance arrangements kind of suit them, whether they're low, middle or high income countries. And my hope is, and I don't think they've quite collectively, or enough of them have learned the lesson yet, and we can see it's going to play out with vaccines. It's already starting, and I hope that this year is the year that, if nothing else, the member states of the WHO, which is a political organisation and it represents the interests of its member states, actually realises that, and it will happen with the vaccine this year, unless everybody has access to the vaccine, nobody can breathe out. And it will play out as it will, but I really do hope that this is a springboard for the true governance reform that needs to happen at the WHO. It's an extremely frustrating organisation to work in, I can tell you. It makes the New Zealand government look like the most well-oiled bureaucracy. However, we are way better off with it than without it. And if it was stronger, we would be even better off.
So just to build on Ashley, I mean, I think we're lucky to have got this far. It's a mess. It's an international mess. And one of the reasons we've got vaccines this far is because they've seen money behind them, let's be honest and quite frank. And yes, we've seen fantastic collaboration, particularly from individual scientists and a little bit across countries. But quite frankly, we're a disgrace as a world, and that we really do need an international government. And the WHO does its best, but it's tiptoeing through an enormous amount of politics. Completely support Ashley's comments, having worked there too, but it's really very difficult. And they're tiptoeing because they are holding out cap in hand constantly to get money, and they do not have control of what they use their money for. So without strong international government, this world is in a bit of a mess. And I think that we've got to get over our country nationalism problems that we're in right now, and we've got to get over individual philanthropists who are sitting on large amounts of money, feeling like they've got the right to run the world. Unless we get up and say this world needs a government, you know, I think we're in trouble with global warming, and we've got to start getting really vocal about it. You know, we're stuck in our own nationalism, all of us, and it's not looking good at the moment, and equities are going to rise. We're going to see measles come back in a big way in the next few years, and that'll be a disgrace to all of us, and that's what's happening. So I'm a little gloomy. I'm hugely excited by COVID vaccines, though.
Just to continue with that sunny theme, perhaps before I open the floor, I'll just ask each of you. I mean, it's clear that to this point, especially when compared to most other countries, New Zealand has had an extraordinary response, but the true quality of our response won't be judged for 12 months, 5 years, 20 years perhaps, once all of the inequities that you've mentioned have been truly measured. In the ongoing response as we stand, what concerns you most? Is there something in each of your respective fields of expertise that weighs on your mind late at night that you think we have to get this right to ensure that New Zealand is in the best place possible?
So to pick one of the things that keeps me awake at night, complacency as a general theme, complacency of ourselves as government, of the people of New Zealand. It's not I don't want that to sound like an accusatory thing, it's just that's what happens. So I'm concerned that we don't allow that to happen, all of that amazing public health work that's been done doesn't get lost. I'm really excited to hear about your excitement about the vaccine, because of all the people I want to be excited about it, it's you. I am concerned about the fact that I'm trying not to be too diplomatic, but also to give the fact that the key to the success of that lies in the hands of a system of pharmaceutical manufacturing and selling and so on that we all know does not prioritise equity.
Yeah.
And I am very, very concerned. We are doing our best. We're part of all the global alliances, and we're working in the Pacific, and we're doing the things that we need to do. But ultimately, we're relying on drug companies and some of those issues you're seeing playing out in Europe at the moment. So that's my concern, is that we do that. I actually think we've got a good plan. I think we're well placed. It doesn't mean it's perfect as ever, but we're well placed. But we are very much in a globally highly charged situation. I could go on, but I won't.
I'll come back. You can come back to me. I just have a think.
I've been asked this a few times, Jack, and the most obvious thing to say is, how will we know if it worked? And the answer is always afterwards. And it is that fragility, I think, that Grant has mentioned, the complacency. Being on teleconferences with colleagues in the UK and the US who are weeping openly on the Zoom call tells you how little we understand about what others have endured, and I think you've had a taste of it when you were in the US. So we have, have we been lucky? Yes, a bit. Have we been smart? Yes. Have we had an agile government? Yes. But we need to make sure we don't take our eye off the ball.
Thanks. I think Ian's expressed it very eloquently. Complacency over the next year. We have to basically continue to keep ahead of the virus. I am concerned about viral evolution. We are in this classic arms race. It is changing. Hopefully it won't get ahead of the tools we've got. But I am concerned now that vaccines on the horizon, this feeling that maybe the problem is partly solved. It's a long way off that. If anything, the force of infection has never been greater, the risks are extremely high, and that's why I think we have to use every tool available very effectively and efficiently. And after that, so the second thing is I'm worried about the entrenched inequalities that this response will create, and we are seeing that in New Zealand now. And so I think that's the other huge challenge, I think, to manage.
Thanks, Michael. So I think the thing that I'm most thoughtful about is just the capacity of the health system to keep all these balls in the air this year. I said to my team when we first came back in the office on the 11th of January, there are two big things the country has to do really well this year, and everything else depends on them. One is keep the virus out, and second is vaccinate the population. Guess what? We've got a pretty big role to play in both of those. So yes, we should feel the pressure, but at the same time, as we've said, the health system has to be involved in leading those responses and keep delivering a whole lot of care to ordinary New Zealanders. And we know that it was a system that was already under pressure. So I think we've got to be very thoughtful about and thinking about what other things we just might have to trade off this year. And one of the things we've talked about is if push came to shove, would we not do the influenza vaccination program because our priority is COVID-19? Would we not do MMR and do influenza? Which one would we trade off because actually the resource is finite, and we have to be courageous enough to provide advice to ministers, and actually ministers are already thinking about this. Minister Verrill has been the first to raise these questions and ask us to be thinking about them. So I think that the one thing I am bothered about and concerns me most this year, and Nikki's talked about repression in primary care, and that will be replicated right across the system.
Thanks, Ashley. I really want to reiterate this one, that we need a system that works for everybody and the most vulnerable who misses out at the same time. And at the moment, we're pretty borderline. Primary care is down on its knees, and I can't say that often enough. We're really struggling, and yet it's a complex system. This issue of if we stop one thing, what happens next? So if we let go of measles, what happens next? If we don't run a flu vaccination program, it's fine this year. I doubt if we're going to see flu, but we will then lose momentum. So the complexity of our system is really the challenge, and hearing the voices within the complexity. I don't have the answers, Ashley doesn't have the answers. We need to put the complex voices together to make the best answer for our system. That's my first problem, is listening to complexity and listening to every voice. We don't do that often enough. We keep talking to ourselves, which is what we're doing today, is again talking to ourselves. So we really need to push ourselves out of our comfort zone. We're motivated by fear and panic for a campaign, and then suddenly everybody feels it's okay and they're complacent. So half the country wants vaccine and then they go, no, we don't. So this is the world we're in, and facing complexity and recognising it. And then I think the other thing is, if we've developed a resilient system, then we're going to make mistakes, and recognising them, being completely relaxed about them, and having the ability to change direction is not something we're very good at. So those are the things that are keeping me awake at the night, both about primary care and about vaccination delivery.
I just want to pick up on David Johnson's point, which was that how do we learn from this experience and ensure that we've got a system that's wired to respond to anything else that comes up. So I think that we've seen all of these things. We've got to invest in public health. We've got to invest in primary care. We've got DHBs that are under pressure. We've got the Simpson report, which is going to be disruptive. Will we manage through that? So all of those things are going to put significant pressures on our system.
And yes, and that's the very reason, and as you picked it up before, we have to have those very honest conversations this year about our priorities are to keep New Zealanders safe from COVID-19 and address the inequities and get the system resilient. And in the end, like a lot of things in life, it won't be one or the other. It will be bits of everything to be the best that we can be. But we are very, very aware of the balance and the trade-offs. Everyone in this room wants big system change for health. But equally, everyone in this room wants to make sure that we are able to deliver the immediate issues. And if we do the big system changes, that demoralised primary care service or the Ministry of the DHPs might not be able to handle it. So it is an incredibly tricky balance, and that's what we all have to navigate through.
Thank you all for your thoughtful comments. What I'll do is just throw open the floor. So please, if you have questions, I'll bring the microphone around and we'll try and get through some.
Minister, one of the most enduring images that I will take away from this period is watching the news during lockdown, and they had gone up to Northland and they were interviewing whānau about they got new camper vans so that they could have warm and dry places to live. And this wee girl was showing the journalist where she used to live. And this caravan had a hole in the roof and it was all full of mould, and she was talking like this was normal. This was every day, it was like jam and toast. It was nothing that was unacceptable. So if we say that poverty is one of the social determinants of health, it's something that's super basic, that we accept that needs to change. Why did the government drop the ball on universal basic income? This period last year would have been like the perfect time to push that through, and then you would have lifted a vast majority of those who really, really need the help up, a bit, so that the burden on the healthcare system is less, the burden on our education system is less, the burden on, the physical health impacts of poverty are just enormous. And I really, really feel like the government had the perfect opportunity to go, this is the best way forward. And you had enough social capital to do that. And most people would have gone, yeah, okay, I can see that. And I just feel like that you guys dropped the ball. Why?
Thanks for the question. You won't be surprised to learn that I don't feel we did drop the ball, but I do get exactly where you're coming from. That those images from Northland are not acceptable. It's not. That's not the society I want New Zealand to be, and I fully recognise that it is, unfortunately, the society that we are. So I can go through now all the big investments that we've made in social housing and public housing, and the huge amount of work that's gone into transitional housing to try to make sure people who are in those precarious situations are drawn out of them. The fact that we are now purposefully working our way through the recommendations of the Welfare Expert Advisory Group and so on. The pace of it is what you're challenging, I think, and I guess it's a depressingly pragmatic answer, which is we did start the work on looking at really big system changes, but the truth was, for similar reasons to the ones we've just been talking about here, that we weren't in a position to do it. So we did lift benefits, and we did expand the winter energy payment, and we did make sure that there were more resources available for people. But the capacity of us as a government and a system to do a major change like that actually wasn't there. So that's the depressingly pragmatic part of the answer. We continue to look at what are the best ways to do the very thing you say. I mean, it is one of our core goals is the reduction and the elimination of child poverty, and so we will continue to work on those. But we could get into a detailed discussion about the UBI and why that might not be the perfect answer to the question that you're raising, but it is still core to our thoughts. But there is a depressingly pragmatic reason for why that moment wasn't taken. Then there's the question of sort of mandate of what to do now. And I would say that yes, we got a fantastic result in the election, but the mandate we have is to do those three things I said: keep New Zealanders safe, accelerate the recovery, and address these issues. We've just got to do them all together and at once.
Come right at the back and then I'll come down.
Thank you. I'm a statistician here at University of Otago, Wellington. I'd like to know why, when diagnostic procedures or vaccination success rates are advertised and published, the public only gets to sort of know one figure of accuracy. So in a diagnostic test, there are two basic ideas. How likely is the test to tell you that you've got the disease, and how likely it's going to tell you that you've not got the disease if you've not got the disease. So one's the sensitivity, one's the specificity, and you cannot describe a test with one number. It is not possible, it's not meaningful. And yet, every time in the media, is always one number. So I think there is fault. I'm not sure, what is the cause? Who is the cause? Is it the public cannot take on board more than one number at once? Is that what the media thinks? Is it what the scientists think, that the public can't cope with more than one number? Or does the scientists think that the media can't cope with more than one number? Who can't cope with more than one number at once? If we were able to think with two numbers in mind, we would be much more informed.
Jack, that one's for you.
No, it's not the media's fault, Robin. Never the media's fault. No, I mean, it's the media plays a critical role in the COVID response, clearly, and the nature of most journalists is that we are generalists and that we actually lack expertise in most areas. That being said, I think most journalists would have the capacity to understand the importance of two numbers, but like you say, most tests aren't publicised in that manner.
Are people like Michael giving you two numbers and you're choosing, or is he given up at that stage already?
No, I think Michael's always very thorough. No, he's always very thorough. I honestly, I don't know why. I don't know why it is. It might just be a habit thing. I think, generally speaking, most mainstream media is probably targeting its message at someone with the intellectual capacity of a 13 or 14-year-old most of the time.
And if they were taught in Form 2 to have two numbers, they have the capacity. They have the capacity.
Just a quick comment, perhaps. That's a great question. I dare say sometimes we're lucky to even get one number. The 50 to 70% increase in transmissibility of the variant of the virus first found in the UK is usually described as highly infectious, so no number. And as is the variant first discovered in South Africa. It's a work in progress. Dare say, Michael, you've got lots of expertise in this area.
And Michael.
Yeah, look, it's a great question. I mean, there's many parts to that. Even the more fundamental thing of what is measured and reported. And frequently, I think the bigger question is validity. We get a number, but what actually, I think that's what you're really referring to, what does that number actually mean in the real world? I mean, how are the numbers collected? And I think frequently we get numbers that are almost meaningless, but they take on a life of their own. And also the question of relative risk, compared with what? Is this good or bad? I mean, there is an obsession with a number, but often it's not necessarily meaningful. And I think one of the things I find frustrating is there's an obsession with testing. A test is positive or negative. And the public does not understand that all testing has to be viewed very critically. And I think the PCR test has taken on a life of its own. If you're negative, phew, you haven't got it. And we just know that is a huge simplification. So, I mean, the bigger question is, I mean, there's many parts to this about science literacy. Science Media Centre has done a fantastic job, but they can't fix the entire education system as well. But I would say I think the last year must have been surely a very vivid, ongoing tutorial for the entire country in thinking about science and numbers, hopefully.
Yeah, I think you probably do the media a bit of a disservice. I mean, some of the questions and the intelligence shown by some of our leading reporters, thinking of Jamie Morton, for example, have really started to explain this stuff in great detail in a very accessible way. It hasn't been released yet, but I've done a number of riveting Facebook recordings on this. And I think the one I'm testing is yet to appear, but actually it's not, it takes time to work through these things, and I think you need more than a slogan and more than a soundbite to get to the heart of the matter. I think that's the problem.
Yeah. Got a question over here.
Ani te mihi o tēnei I whakaheke o Waikato Ngania Poto Taranaki Ngātipura ko ka whakahau no te rau ora. Mihi atu kia koe e Jack mo tō kaha whai hai te tātou reo rangatira. Tai atu kia koutou ana mo te kāwanatanga, koutou nā rangatira o tēnei kaupapa I tēnei wā. So I'm just going to make some comment. Yeah, so you should never forget the communities and the people that we work for, because they gave their hearts to this kaupapa after we were told it's a lockdown. You know, that word was offensive to Māori. What resonated with them was the protection of our whakapapa. And that's what we went on. We went on the protection of our whakapapa. So don't use lockdown around me or any other Māori, because I don't think so. So continue with that, the protection of whakapapa, an intergenerational strategy that lives on with us. So I had the pleasure of working with a huge number of Māori providers across this mortuary and this document. Some of you actually got it because our organisation sent it to you and said this is what our communities are doing. I was thankful that Professor Baker took one today. I've already got another copy, and that's for Helen this afternoon, the World Health Authority, because that says what worked for them. There was no waiting, there was no civil defence, there was no waiting for ministry funding, anything to come. They went out and did it because they knew where people were and how to do it. So I aligned this with the immunity strategy and the vaccinations going on. I want to thank you, Nikki. I pursued your cell phone, your contacts, because I wanted to thank you. Because you know you were about the 10th speaker today, and you're the only one who mentioned the Treaty of Waitangi. Because that's the equity basis. That's the equity basis of this. And you're the only one who did it. Hey, karoha. So I'm going to give you an electronic copy of this. Unless you say you don't want to get it, but here are all the contacts. All the contacts of all the providers. One of them is here at the back there. No kura hau ora Tame. And there they all are. And they were amazing. They're magnificent. They're magnificent in their contact. Now, if you're going to do an immunisation, you've got to get them on board, because they do it with heart and soul for the people that can serve. So if you're going to run one out, get hold of them. Their emails are in here, their contacts and who they were and where they are. And I said I was coming today on their behalf to distribute, and I'm sure if you contact them, they will. There's webinars with them talking on it as well. And you know, I've been honoured, we've been honoured and privileged to work alongside them to get that out. So it's interesting, someone today before you said that actually the rates have dropped around influenza and all of that during the COVID. The only ones that remain are rheumatics and TB. I thought, oh, how come? And but he just contradicted that and said, no, we were shopping with our flu vaccination. So it can't be that. That didn't work. It was a mess, he said. But we were all in looking after our wakapapa, so no one was in the community to get the influenza. So a couple of them here did magnificently. Naitapu, the iwi or Naitapu, they went out there and they vaccinated everyone in the bottom of the south. And you can get you'll see it. So all the best for that, and I'm still going to keep and send your e-copy and tēnā koutou.
Any more kātai? Okay. Try and burn through a couple more, then these guys have got to go.
Kia ora tātou. Hey, my pātai really is around the mixed messaging, that when we did go into the first level, alert level 4, there was a message, to stay home. And because I work in primary health, a lot of the people wouldn't come to the GP clinic. So we had, so there was a lot of mixed messaging. So this question is around the rollout of the vaccine and the flu jab, and the mixed messaging that's going to impact on the communities that I work in, particularly Māori, in Waikato and in South Auckland and Pacific too, is what's going to happen with that? How are you going to provide clarity to these populations around, do I just go and get the COVID vaccine, or do I get the flu jab, or do I get both, and all of that? So that's my part of it.
Kia ora, a very relevant question, and we certainly had problems last year. So there's a few different answers to this. Ashley's point about whether we should be rolling out a flu vaccine or not has certainly been discussed widely by us. I think the general feeling is that if we don't roll out a flu vaccination program at all, we'll get a very confused community saying, well, you can just stop it for 1 year. On the other side, from a science point of view, the latest 3 isolates in the country of flu have all been from MIQ. So whether we've actually got flu in New Zealand or not, we're actually not sure, which is a fascinating science question, but it doesn't mean we can get complacent about flu. So assuming that we are going to roll out a flu vaccination program, currently we are hoping that there'll be a staggered approach where the early COVID vaccines that are coming very soon will be for border staff, their families in MIQ facilities. So that will be a small, limited number. Hopefully all going well, which sometimes it does. We will rock out a flu vaccination campaign smoothly through primary care and pharmacy as quickly as we can, so that then straight after that we'll be rolling out COVID vaccines to the broader community. So what we hope we've got on our side is a bit of temporal staggering between the two approaches. But you're absolutely right, this is a critical question and the key communication question. We're actually following this up with the College of GPs and a big GP webinar tomorrow night, and these are exactly the issues that we need to talk about and land on and decide, yes, this is the way to go, or it's uncomfortable. I think we're also deciding that COVID will be prioritised, but you won't have COVID vaccine for everybody who needs flu straight away, so you've got a chance to get flu into people. So that's the answer such as it is today, and we need to keep communicating about it.
I'm aware that our panelists are busy, so maybe just time for one more question, and then if you have a specific one, you can bail someone up on the hall afterwards.
Tēnā koutou. This is a quick one. I want to ask about New Zealand's next pandemic plan. And just before I start, I want to say thank you very, very much to the panelists for their stupendous hard work this last year. I sometimes get comments published in the media, and they always say publish the critical stuff, and they never publish the very nice things I say. So it's very nice to have a chance to say a nice thing. Thank you very much. My question about the pandemic plan is, we can't just do a copy-paste for our next one. It's got to be very different. So what do people think is going to be the most important difference for the next pandemic plan?
Thank you, and thanks for your thanks as well to the team here. But I think the important thing for me is we had a plan that was about 2.54 centimetres thick, with an enormous amount of detail We had tested it, and we were down to the line by line about who would do what on what day. And of course we got a few weeks in and realised, holy heck, if we do that, we're going to be in a power of poo. And so so it seems to me our pandemic planning needs to be less about the detail and more on having really strong pillars. And I think this goes to what the Deputy Prime Minister said about having that all of government mechanism ready to go and tested and tried, not the detail under each pillar, but actually just the broad approach, and again, how we will stand up rapid, integrated decision-making, strategic thinking and operational delivery without spending all our time sort of wargaming all the details.
Yeah, I absolutely agree. I mean, the abiding message from this year is that you can't have a plan that's tied to one pathogen. It's got to have, it all has its approach. Excuse me. And in a sense, that's built into the international health regulations. They were, and that was in 2005, and it was a reaction to the old international health regulations, which listed 4 pathogens in a schedule. And it said, oh no, that's no good. We have to have regulations that can adapt to any pathogen, and it had an algorithm in there for assessing pathogens. Amazingly, that doesn't seem to have translated into a change in how our international agencies have behaved, despite that huge shift in thinking. And I think that's well recognised, and that may be one of the many changes that come from the review of the World Health Organization.